Hello and welcome. My name is Anna Dragsbeck. I am President and CEO of the Immunization Partnership. TIP's mission, for those of you who are new to TIP, is to eradicate vaccine-preventable diseases by educating the community, advocating for strong laws and policies to support immunizations, and supporting immunization best practices. We invite you to come and have a look at our website. We have a lot of resources on there for providers as well as for families. And the email or the website address is immunizeusa.org. So today we are going to be doing the panel or the forum on pertussis that we had to cancel due to the rain in Houston a few weeks back. So we really appreciate everyone showing up again and having patience and flexibility with rescheduling. This is a little different format than we had originally planned, but we hope that you will find it informative and useful. So I'd like to thank our partners, the Houston Department of Health and the Houston Health Department, as well as UT Health and UTMB. We could not have done this webinar without help from all of those folks, and we greatly appreciate it. That's the wonderful thing about our community. People are very anxious and willing to get involved with lots of different projects. So we thank our partners, and I would like to hand the meeting over to LaTosha Hinkson to give a brief welcome on behalf of the Houston Health Department.
Hello, everyone. My name is LaTosha Hinkson-Callis, and as Anna said, I'm with the Houston Health Department, specifically in the Immunization Bureau, and I want to start again, as Anna did, by thanking everyone on the call for your interest in pertussis and also for joining the webinar to learn more about the disease epidemiology, as well as strategies to prevent it. I want to also provide a brief overview of some of the things that we do within the Immunization Bureau, which include managing medical providers in Houston and Harris County that are enrolled in the Texas Vaccines for Children's program. In addition, we have staff that conduct immunization audits in daycares and schools. We also assist with enrolling individuals in NTRAC, which is the State of Texas Immunization Registry, and also a team that conducts education and outreach. Lastly, we have a team of nurses and investigators that provide perinatal hepatitis B case management in Houston and Harris County, as well as VFC compliance audits. So with that mouthful, I want to thank you again for joining, and I know you'll learn a lot. Anna?
Now, thank you, LaTosha. I would like to now introduce Robin Correll-Carlisle. Robin is the Education Program Manager for the Immunization Partnership. She is responsible for developing the content of most of our educational programs. This program is one that she created the content for, and she is going to give you some very important instructions about your continuing education credits as well as some housekeeping items. Robin, go on.
Thank you, Anna. So as Anna mentioned, this is a continuing education event for both nursing and medicine. And the best thing that you can do for instructions on how to receive credit for participating in this live webinar is by going to this page right here on your screen, immunizeusa.org/education/pertussis CEU, and this link will be up on several of the slides that we have, and we'll remind you throughout the meeting. And it will have information about where you need to go to sign in, because you will need to sign into the appropriate login sheet, as well as information about evaluations and how you can receive your credit. To give you just an overview about conflicts of interest, thankfully we don't have any conflicts of interest to disclose. Our only, I think, anything that we want to disclose is that we are anti-pertussis, and we would like to see pertussis go away, especially in young infants here in our community. But our planners and our speakers today do not have any conflicts of interest to disclose. For nurses, this program is worth 1 contact hour for nurses. In order to receive this 1 contact hour, you will need to sign in on the CME sign-in sheet, which is at that webpage down below. So immunizeusa.org/education/pertussis Pertussis CEU. You will get a link to an electronic sign-in sheet, and we will be able to use that sign-in sheet to then reach out to you and contact you about your certificate. You will also need to attend the entire presentation and turn in your completed evaluation form, which again is on this webpage, and it's an electronic evaluation. Just some information about reporting of perceived bias. This is part of the evaluation. If you do perceive bias, please let us know. And again, that's on the evaluation that's found on that webpage. To read this more in depth, I won't read it verbatim here, but this information is also available on that webpage. There is a PDF that you can open up and download that has all of this information if you'd like to read it more in depth. There's lots of really great information about perceived bias and avoiding bias. Some learning objectives today, we are going to learn about the current rates of pertussis here in Houston and how they compare to state and national levels, as well as what subpopulations are more affected by pertussis than others. We'll also be talking about what recommendations currently exist to prevent pertussis in young infants, as well as describe some of the challenges and opportunities that we have in implementing these recommended strategies. For those who are seeking continuing medical education, the process is slightly different. On the right-hand side of your screen, you'll see a lot of different tabs that you can drop down. One of those is handouts, and underneath handouts, you'll have information about CMEs, the NEs, as well as the slide notes today. So if you're interested in following along on your own slide deck, or if you want to go ahead and print them really quickly, we have the slides already available in PDF form for you to follow there. And you can get the handout section. In order to receive the medical credits, which is 1 contact hour, go ahead and you need to read that document. It has the disclosure statement as well as information about credit tracking. You'll also need to sign in on the electronic sign-in sheet. So again, at that page, immunizeusa.org/education/pertussis-CEU, there's an electronic sign-in link. Please sign in on that link with your first name, last name, and email address. And then we will email individuals who have signed in on that sign-in sheet with the evaluation, and we'll email you tomorrow. And that evaluation link, that email will also have not only the evaluation link, but instructions on how you can receive your certificate. Now moving on to some housekeeping items. So as I mentioned, the slides today are available under the handout section. We'll also have them uploaded onto the event webpage, and Anna mentioned our website is immunizeusa.org. To get to the event page, you can just go to immunizeusa.org/events. And many of you probably went there already to register for this event, so it'll be the exact same page that you went to register. You'll be able to find the slides there, and that will likely be loaded up early part of next week. And then throughout the presentations, we will not be taking questions throughout. After both speakers have completed their presentations, we'll have a Q&A with both of our speakers. Throughout the course of the presentations, if something comes to mind, if you have a question that you want to ask the speakers and you don't want to wait until the end, please feel free to just go on the right-hand side and type it in the questions box. And similarly, if you have any questions that are related to the webinar or anything related to CE, please feel free also to include those in the questions box or in the chat box. You can also chat the organizers, and we'll be sure to answer your questions throughout the presentation. Also, if you haven't completed the pretest, please take a minute to do so now. In the reminder emails where you received login information about how to sign on to the webinar, there was a link in there to the pretest. I strongly encourage you to go ahead and just fill that out very quickly. It's 5 questions that are the pretest questions, as well as potentially demographic questions, so please take a minute. It takes a few seconds. Also, at the end of the webinar, we will have an evaluation asking how we did, and we'd really love your feedback. In addition to that post-webinar survey, there will also be the post-test questions. And so we really appreciate you taking that minute to fill it out. We do take those things into consideration. A lot of the content that we work to provide are based off of feedback that we've gotten in the past, and so we really appreciate those comments and those recommendations. And then just a small thing, if you have to, for some reason, step away from your computer, please do not place your phone on hold. Sometimes that can cause phone music, hold music, especially if you're still in an office setting. So please just go ahead and just place the phone on the desk, or just step away and not place your phone on hold. All right, back to you, Anna. Thank you. Hannah, I believe you're muted. All right, well, we seem to be having some issues getting Anna on the line. We're not able to hear her, so I'll go ahead and I'll just do a brief agenda. And Anna, if you're able to get back on, please feel free to pipe in. As you already saw, we do have some welcome and introductions that we gave. We really do appreciate you being on the call, so thank you very much. We'll be talking briefly with Essi Havor, who is the chief nurse, who will be at the Houston Health Department, who will be going over the epidemiology of pertussis. And then we'll also be having Dr. Michele Curtis, who will be talking about the current strategies for reducing infant pertussis, as well as what are some other strategies, some needed strategies or underutilized strategies that would be beneficial in preventing transmission of pertussis in infants. Then after that, as I mentioned, we will have a Q&A where you'll have an opportunity to ask your questions, and then we'll adjourn. And so hopefully we will not keep you on hopefully until 8 o'clock. We do have this webinar scheduled from 6 to 8, but we don't want to rush the content. But it's in the event that we need to step out early, hopefully we'll be able to get everything completed before that time frame.
Robin, can you hear me now?
Yes, perfect timing, Anna.
Okay, wonderful. Thank you. Thank you, Robin. I'm not sure what the problem was with my phone. So I want to tell you the story about the Throgmorton family. You probably already know what the ending of this story is just by looking at the picture. But we always feel like it's important to tell the story to honor people who have lost their lives to vaccine-preventable diseases, as well as to put a face and a name to some of these diseases, because we find that that is really what makes people remember their stories and remember why vaccines are so important in our community. So I would like to introduce you to the Throgmortons. Dad is named Rodney. Mom is named Jerry Lynn. They've got a gaggle of children, as you can see there. And Jerry Lynn was pregnant with their third child. It was a girl, and they were very excited that it was a girl because they already had 2 boys, and so they were looking forward to adding a girl to their family. And Haley came early. Haley was actually born on the kitchen floor. Jerry Lynn went into labor, and Rodney actually delivered Haley as a healthy, happy baby. As you might imagine, this made the news because they live up in Amarillo, and they are that is a big story up in Amarillo, a baby being born on the floor. So they were all over TV, and the whole community was celebrating, and it was a good story to be told. So Rodney's mom came to visit because, that's what grandmas do. So grandma came to visit, and of course, oohed and awed over the new baby, Haley. And Grandma was coughing when she got to the house, but she had been coughing for a long time, and she didn't really make too much of it because it had been around for such a long time. What she didn't know at the time was that she had pertussis, which is also known as whooping cough, which is also known as the 100-day cough because the cough comes, it's very severe, and it stays for a long time. But she didn't know that at the time. And so, she was in the family, and an important member of the family, taking care of Haley, coming into contact with everyone in the family. And pretty soon, Rodney started coughing. And he said that it was just a remarkably powerful cough that he had. And there were times when he couldn't catch his breath. So it was really bad. He had never had a cough like that before. So he started taking care of himself, and it didn't do him any real damage except the cough was really bad. But then Haley started to cough. Now Haley at this point was only a few weeks old. Her lungs were not fully developed, and newborn babies are very vulnerable. So Haley started to cough, and that got them a little bit worried. And pretty soon she started coughing so hard that she started to turn purple, and they knew that that was not right. So they rushed her over to the hospital, and when they got there, they diagnosed Haley with pertussis. And pertussis, as many of you are probably well aware, is a very, very dangerous disease in infants because they can't cough with the same power that adults can, and so the bacteria gets trapped in their lungs, and it can be fatal. And so Haley was put on all kinds of ventilators, and she was put on drips and everything, and they tried to stabilize her. And Grandma brought the boys in to visit. And so the boys, went up to the ICU, and they got to visit Haley. And then it was time to go, so Grandma and the boys left. And about 5 minutes later, they got a call from the doctor. And the doctor had informed Rodney that it was getting pretty bad. And so Rodney called his mom and said, "You better bring the boys back up here because things are getting pretty bad." And they all went back up to the hospital. And the only place on little Haley's body that wasn't covered with a tube or some kind of medical apparatus was her little bottom. And so the boys kissed her on her bottom and said goodbye and left the hospital, and a little while later, Haley died. You can see from her tombstone that she lived from June 8th to July 22nd, just not a very long time. And Haley represents for us all the babies who are so vulnerable in our community to pertussis. And so as we're talking about pertussis today, I think it's important to remember the Haleys of the world because they're too young to protect themselves. In fact, you can see Rodney's quote on the left-hand side of your screen. Haley was too young to receive the vaccine. It would have saved her life. Well, because the babies are too young to get the vaccine, that's why we need to make sure that we're all protected and that we come up with strategies to protect infants. And so today, you're going to hear about some of those strategies, and you're also going to hear a lot more about the pertussis vaccine and the burden of the pertussis disease in our community. So without further ado, I'm going to introduce Essi Havor. Essi Havor currently holds the position of Chief Nurse within the Immunization Bureau of the Houston Health Department. In this position, she provides leadership and managerial oversight to the work and quality assurance team, coordinates different immunization outreach activities, and provides education to the healthcare providers on immunization best practices and vaccine preventable diseases. Today, she will share information about pertussis trends in Houston. Welcome, Essi.
Thank you, Anna. Hello, everyone. My name is Essi Havor. My presentation tonight will provide an overview of pertussis epidemiology in the city of Houston. First, I will start with a basic overview of pertussis, including the clinical characteristic, and briefly touch on the laboratory diagnosis for pertussis. And we'll also take a look at the current epidemiology, including some of the changes that have occurred over the last decade or so. This will include nationwide and in the state of Texas. And my great emphasis will be on the importance of protecting infants from this serious disease by vaccinating pregnant women in the third trimester prior to the delivery. So as we know, humans are the only known reservoir for Bordetella pertussis. The organism attached to the cilia of the upper respiratory system and are transmitted through coughing and sneezing. So after attachment, the organism releases toxins which damage the cilia and cause them to stop moving. Coughing is the body's reaction to the damaged cilia and may continue for weeks after the organism is gone. And the cough is initially intermittent and becomes paroxysmal. In typical cases, paroxysm terminates with inspiratory whoop and can be followed by post-tussive vomiting. This may occur more at night usually increase in frequency and severity as the illness progresses, and typically it persists for about 2 to 6 weeks or more. And as we know, unvaccinated or incompletely vaccinated infants younger than 12 months, as the story Edna shared with us at the beginning, they are higher risk for severe and life-threatening complications and death. Young infants have the highest rate of disease and serious pertussis-related complications, and it makes the diagnosis really complicated, challenging, because just like Anna mentioned, most of the time it's hard for them to breathe. The cough is minimal or absent, and apnea with cyanosis or without cyanosis is most of the time the common symptom, along with sneezing, gagging, choking, and vomiting. So it's very important, and it's recommended that presumptive treatment begins immediately. Otherwise, most of the time we end up in tragedy like the story that was shared with us earlier. So the current definition of the current case definition include a component of the clinical presentation which require at least 2 weeks of cough in addition to at least one symptom, such as paroxysmal of coughing or inspiratory whoop or the post-tossive vomiting, especially if the child or the infant is less than 1 year. You know, like I shared with you earlier, it may be apnea with cyanosis or without cyanosis. So now we'll look at the diagnostic testing for pertussis. Okay. First, let me say that the direct fluorescent antibody and the serologic test to detect IgG and IgM antibodies to toxin have not been clinically validated and are not generally recommended. So the best testing that are recommended by CDC, the first one is the culture, where we isolate the Bordetella pertussis from a clinical specimen, or the PCR positive polymerase chain reaction assay. PCR is an important tool for timely diagnosis of pertussis, and is the dominant test that we see on the market. It's the most rapid test, and the specimen should ideally be collected during the first 3 weeks of illness, but may provide accurate results for up to 4 weeks, meaning that when the patient comes in, immediately when they start having the symptom within the first 4 weeks, when we do this test, you know, the result is accurate. Pertussis is, the culture is the gold standard, and they prefer also lab tests because it has better specificity, but the only issue is it takes up to 7 days to obtain the result. And you know, especially when you are dealing with infants, time is, you know, critical, so we need to make sure we intervene timely. And the specimen should ideally be collected during the first 2 weeks of illness. So as you see, I'm having some issue moving. Okay, there we go. As you see, the stage of the disease is an important factor impacting the clinical accuracy of the diagnostic test, in addition to ensuring that the specimen is collected accurately or correctly. And for some of our providers, we recommend that it has developed best practices guidelines for the healthcare professionals how to collect the specimen. It also includes little video where you can learn how to really collect the specimen without contaminating the specimen. And you can find that on the CDC website, cdc.gov. Okay. So this graph gives an overall picture of pertussis incidence in the United States from 1990 to 2014. And as you see, the purple graph represent the highest incidence rate, and this depicts 2012 when we had over 48,000 cases reported, which was the largest number actually reported in the U.S. history in over 55 years. The incidence rate decreased in 2013 to 27,000 cases. But then we noticed that in 2014, it picked up to close to 33,000. And also, when I was checking the data for 2015, it decreased to 18,000 cases. So in looking at pertussis cases by age group, we see that infants less than 12 months of age account for the greatest number, as you see here, right here in the purple graph. When the data is broken down a little further, we see high number of deaths among children less than 3 months. So when we break out the 1 year, we break down the 1 year infants who are affected less than 1 year, we see that infant less than or newborn, infant less than 3 months are the ones that are highly affected because of this age group. You know, they are too young to receive the vaccine, and it's very important that we protect them by immunizing the siblings and people who surround them during this time while they are waiting for the vaccine. Also, it goes back to the importance of immunizing the pregnant women in the third trimester and in each pregnancy. You know, as a nurse, what I see most of the time, doctors usually rely on delivery hospital to give this Tdap to the pregnant women, and that whole process, if we wait till delivery, it defeats the purpose of protecting the infant, because CDC recommendation is to give Tdap during the pregnancy, preferably in the third trimester, at least 4 weeks before the due date, to be able to give some antibody to the infant or to the fetus. So what do we see in Texas? In state of Texas, from 2010 to 2014, we see similar trends compared to nationwide. This graph is showing the incidence from the 2010 to 2014, and you notice that 2013 is the highest incidence that we have seen as well. And if you recall, this was the year where we experienced the whooping cough epidemic in Texas. The highest number of cases reported in over 50 years as well. So in 2013, we had about 4,000 cases that were reported. And in 2014, it decreased to 2,500 cases. Now let's look at what's going on in the city of Houston. Pretty much same trend in the city of Houston as well. Houston was also affected during the 2013 epidemic that was noticed in state of Texas, where we saw higher number of pertussis cases. As you see, when you look at the month at the bottom, you will notice that the peaks in disease occur usually in May through July, where you see the highest incidence. Now, when we break up the data, we break down the data by sex, we notice that we see that the incidence is higher among female compared to male. And the blue graph is showing the female rate. And as you know, the case that we have out of the 4,000 cases in 2013, females were mostly affected. The age. So again, you know, it's very important that we immunize our infants, you know, children less than 12 months, because the incidence, again, is higher among those groups compared to the older ones. Now, based on the data that we have in the city of Houston, we see that the Hispanic, which is the green, kind of lime green line graph right here, the Hispanics, we see the incident in that population or that ethnicity more than the other one, followed by the white. And the best way to explain this is because of the low immunization coverage rate among the population. So we do understand that we have a lot of work to do in this area to increase access to vaccine and also reach, how to reach people, meaning that especially if they cannot go to area to get services from federally qualified health center. Maybe they may be undocumented, they don't want to be known. So there are multiple factors that affect the low coverage rate among this population. For the white ethnicity, one of the things that one of the factors would be the refusal to receive the vaccine, due to religious or personal belief. That's the purple line. So we know that, again, in state of Texas, our number of exemption is very high, and that's something that we need to work on as well. So before I conclude my presentation, I just want to quickly review the laws in Texas and also how what the providers, the healthcare providers, supposed to do. They must report any confirmed or probable case to the local health department within 1 work day. Usually, some providers are not aware of this. It may take a little longer, but we want to make sure that everyone is aware of the rules. And if you live in the city of Houston, the local health department will be Houston Health Department. In Harris County will be Harris County. But either way, it's good to report to one health department, and we'll take it from there. And you must do so in 1 work day. For the laboratories, they must report immediately to the healthcare provider if the lab is positive. And also, they are required to report to the local health department, either City of Houston, Harris County. And usually in the City of Houston, many labs, they report this through our electronic system, which we call ELR, and they report that. That's how most of the time we get the lab. For the outbreaks, they must be reported immediately for better preventive measure and control of the outbreak. As we discussed earlier, we know the high incidence of pertussis is observed in Hispanic female, especially the infant less than 1 year of age, and also the unvaccinated. We know the incidence is high among unvaccinated people. And the majority of the cases, usually we notice that between May and August, which pick up June through July. So there are multiple studies showing the waning of the Tdap vaccine 3 to 4 years after vaccination. But as of today, one thing we know for sure is vaccination remains the best prevention tool, and we should continue to maintain high level of DTaP or DTaP among our children, and also sustain the Tdap coverage in adolescents or teenagers, and most importantly, increase Tdap coverage in adult and pregnant women throughout the county. And this is the only way we'll be able to protect these infants from this deadly disease. These are some of the references used for the PowerPoint. And this presentation is from the epidemiology department. And I want to thank the epidemiology department, the staff, and all the patients who constitute the cases that we discussed. And Thomas Johnson, who put the PowerPoint together, is a public health investigator with the city. And also the funding agency for our surveillance is CDC, so we want to acknowledge them. We want to thank them for their support. This concludes my presentation. So back to you, Robin. Robin?
Yes, hi, Essi. I'm sorry. We're going to kick it back to Anna. And Anna, are you having, I see that you're muted.
I should be on now. Can you hear me?
Yes, we can.
Okay, thank you. Okay, thank you, Essi. I appreciate your presentation. It was very interesting. Particularly, you know, the summertime peak. I think it's very timely that we're having this webinar now, and we hope that you'll all keep an eye out for pertussis and to certainly report it to the health department if you see it. I think it's particularly interesting that the Hispanic population has such a high prevalence of the disease. And you know, this is a very complex disease because the resurgence of pertussis, there's no one cause. It's a bunch of factors. The vaccine waning, the immunity waning, the vaccine not being as effective as it used to be, and coupled with the large number of unvaccinated people in our community. So very complicated, and so we're happy you're all here to learn more about it. A quick reminder, if you are if you have any questions about any of our presentations, please type them in the little box. You can see where that arrow is pointing. Put them in there, and then we'll have time for questions later. And for instructions on obtaining CEUs, please go to our website. That is posted right there, immunizeusa.org/education/pertussis-CEU. Thank you. Okay, so I would like to introduce Dr. Curtis now. Dr. Curtis is an obstetrician gynecologist with expertise in women's health, health policy, bioethics, and medical law. She has been recognized for her ability to explain complex medical issues to leaders of healthcare systems, policy and business professionals, politicians, patients, families, and students. She has a history of designing and managing successful clinical trials and studies, persuading key funders to participate, and reviewing grants for the National Institute of Health. Her experience includes working in clinical practice and academic medicine and the U.S. Senate, and advising for disease control and the American College of Obstetricians and Gynecologists. Dr. Curtis will be discussing what current strategies exist to prevent pertussis in young infants and what more can be done to protect this vulnerable population. Dr. Curtis, welcome.
Thank you, Anna. I really appreciate that. Welcome, everyone. Thank you for joining us. It's been a bit of a haul to get here due to the weather not cooperating, but I'm glad that you're here. So I'm going to start first by showing a slide that Essi was kind enough to show us a few minutes ago, which is this epidemiology slide. But I want to point out a few things in the background. As she mentioned, pertussis itself is sort of I think of it as a 3C disease. The first C is that you show up thinking you have a cold. You have a respiratory infection, you don't feel that great. Anywhere from 1 to 10 weeks later, you have a cough. And then, of course, eventually, after 10 weeks have passed, hopefully there is an episode or a period of convalescence. So it's cold, cough, and convalescence. The problem, of course, is that there are infants who tragically don't make it to convalescence. The other problem is that because people think it's a cold, because many practitioners don't think of pertussis when someone comes in with an upper respiratory infection, either the diagnostic tests are not done or they are done, but it's fairly late in the course of the disease, and in fact, they come back negative, or they may come back negative even though the patient actually had and is recovering from pertussis. So at the start of the 20th century, pertussis, or whooping cough, actually killed more children every year in the United States than both measles and polio combined, which most people are not aware of. It is a deadly disease. Now, the vaccine that we used was called a whole cell vaccine, and we used that up until about 1992. And then we switched, and out of the 5 doses of the series, we began to use an acellular pertussis vaccine. And by 1997, we had actually switched, so the entire series was an acellular pertussis vaccine. The reason that we did this is because there were reactions to the whole cell vaccine, and there was, for a time period, some concern based on a study out of the UK in the late 1970s that the whole cell vaccine might actually be associated with an increased risk of brain damage. This was later found to be untrue. Unfortunately, as we're all aware, once the idea that something causes problems of such magnitude as brain damage is out of the bag, you're not going to get back in the bag again. So in the course of the years after that unfounded, or the findings that were not true and later found to not be true, many of the vaccine companies got out of the business of making the vaccine. There were obviously an incredible number of lawsuits that ensued. And unfortunately, then what happened is that people stopped getting vaccinated. There was a huge increase in pertussis. There was an epidemic. And so this drove, fortunately, the research to try and find an alternative form of vaccination that did not involve the use of whole cell vaccinations. And we were able to do that. And we found that it had fewer side effects. And so the thinking was this would be a better vaccine to be used. Now, after 1997, because the studies of the acellular vaccine showed great promise in terms of providing a really strong immunological response. But in the early 2000s, we started to see, as you can see in the lines that are both green and orange here, and then the yellow lines, all of a sudden we started seeing this resurgence in pertussis cases among children who were either 7 to 10 or 11 to 19 years of age. The other interesting thing about pertussis is that even with the whole cell vaccine, we have these cyclical courses of pertussis. It would come and it would go, it would come and would go. And they were in fact related to the prevalence of vaccination, but also other factors that we still don't completely understand. However, when we started to see this reemergence in these younger children, that they weren't the infants, but these were children who should still have theoretically been protected, the reality was that, we need to give them a booster, and that the immunity they were getting from the vaccine was not as long as the immunity you might get from a natural infection. The immunity from a natural infection is still not lifelong. It's not like many other bacterial diseases or even viral infections that we get. The natural immunity itself may only last between 7 to 10 years, at the most 20, but we've seen people who have had pertussis and within 3 or 5 years they actually get it again. So the real question then is what's going on? First of all, there's no vaccine that seemed to have completely eradicated these cycles, but they certainly dampened down the incidence. And what we found is that after we had switched to the acellular vaccine, the severity of the disease actually seemed to also increase, which led us to wonder whether or not it was actually controlling transmission. And what we found is that, yes, there does seem to be a control in the severity of the disease with the vaccine, but perhaps not as great with controlling the transmission of the disease. Now, pertussis is a really hard disease, as Anna mentioned. This is not like diphtheria. It is not like tetanus, even though it's wrapped up into the same vaccine module, in the sense that those are illnesses caused by an actual toxin. Pertussis does make toxins, but those are not the only reasons or the only mechanisms by which it causes the disease and the clogging of the lungs. And eventually, because the cilia, as Essi mentioned, can't sweep any debris from the lungs upward, and then we normally swallow them during without even knowing that, the debris accumulates in the far reaches of the lungs at the interface where the oxygen should be coming into the blood and the carbon dioxide should be going out of the blood. That transfer doesn't occur because it can't, because those final endpoints are basically swollen, they're edematous, they're damaged, and they're filled with debris. And so pertussis, ultimately, when it is fatal, is basically a bacterial disease that leads to an internal drowning and a suffocation. Now, the problem as well with pertussis is that it's extraordinarily contagious. For as contagious as we thought, as we know that Ebola is, or some of the other more heinous hemorrhagic viral fevers, pertussis is actually 6 times more contagious. The disease occurs when people are exposed. The bacteria attaches to the cells in the respiratory tract. It causes changes in the immune response to those, the attachment of the bacteria and the toxins, as well as the cell factors that it releases. The tissue becomes damaged and some of it even dies, and as a result of, and then eventually, hopefully, there's some clearance as people get through it. But it's a very long disease. The virulence factors, some of the contagious factors, are related to some of the toxins, and the acellular vaccine covers, for example, the pertussis toxin, but it doesn't cover some of the other factors that might interfere with the actual functioning of the immune system, as well as the cell death that we see. So it's very important. We only want to decrease transmission, but we would also like to control the severity of the disease and the response to the disease. Unfortunately, what we're finding, as this previous slide shows, is that the new vaccine doesn't seem to be quite as effective as the old vaccine, but there's going to be a trade-off. Do we go back to the old vaccine, the whole cell, which is used still in developing countries, in other countries around the world, but it does not annihilate pertussis. However, there is a trade-off of an increased risk of side effects or local reactions to that. So let's look at what we can do. And right now, what we can do is use the best weapon that we have, which is the vaccine. Is it perfect? No. Is it the best answer we come up with? I certainly hope not, and I don't think so. But it is the best that we have right now. So the current strategies for trying to address pertussis are to vaccinate children early, vaccinate them in their teen years, a concept known as cocooning I'll discuss, and then, of course, vaccinating the women when they're pregnant, as well as the adults. Now, for the early childhood vaccinations, the vaccine, as I mentioned, it's not as effective as the whole cell vaccine, but it is effective. I'm not trying to say that it is not and that it's not worth getting. It's absolutely worth getting. In fact, 98 out of 100 kids who get all of the vaccines are fully protected in that year after that final dose. As Anna mentioned, however, there's concerns because the immunity seems to wane over time, so that by about 3 to 5 years after the final booster shot is given, you may see full immunity in only 78% of the children. So we know that we have to have these boosters. The acellular vaccine does provide, as I mentioned, the immunity, and so we know that we have to give the boosters, and we do give the boosters. Now, what about the children who do or don't get vaccinated? And what we find, of course, is that the national average is that anytime you have a series of shots that take more than one shot, people start out with the best of intentions and they get the first shot, maybe the second shot, but then it starts to fall off. And you can see that in the slide here, where nationally there's a pretty good uptake in terms of at least 3 of the shots here for children who are 19 to 35 months of age. But then it drops off after the 4th, and then this doesn't follow that age group who are recommended to have that 5th shot or the booster vaccine. Texas is a little bit less than the national average, but fortunately Houston on the 4th shot at least seems to have risen above the Texas average as a whole, which I think is in large part due to the incredible efforts on the part of the City Health Department, because there was a time when the City of Houston had a terrible reputation in the state as having a worse vaccination rate than some parts of Mexico, and we have clearly started to address that and to try and improve that. Now, the adolescents that we have and the adults, we did see, as I mentioned, and we saw on that slide earlier, that there seemed to be an increase in the incidence of disease in children 11 to 19 years of age by 2000. In fact, what we found by the 2000s was that there was more disease in adolescents 11 to 19 than there were in kids who were 1 to 10 years of age. The peak of that seems to have occurred in the years 2004 to 2005. At which point we said, okay, we have to have this booster shot because these kids are getting a vaccine that should have been protected for longer than it seems to be. So with the booster shot initiation in adolescents around the age of 11 or 12, we did see, if you go back and look at the epidemiological slide, we did see a slight reversal in that trend. Part of the problem, however, is that kids who are 11 to 19 years of age, adolescents and young adults, are often around younger children. One of the factors we know that plays into both the epidemics as well as this increase every time we have an outbreak in pertussis is that families more and more are becoming multi-generational. This was probably most aggravated by the economic downturn of 2008, but culturally in some instances that's actually the norm. Parents live with the parents. You stay and you live with your parents until you're into adulthood or until possibly you're even married. And so we have multi-generational households, and we chased after and we worked really hard to try and increase the vaccination rate among young children and in early childhood. We learned 15 years ago we needed to also then be just as diligent and chase for the 11 to 19-year-olds to give them their vaccine booster. And now the question is arising, well, maybe we need to start also chasing the adults as well as the pregnant women, which is a separate subcategory I'll talk to later on. Because we know that the acellular vaccine doesn't seem to last as long in terms of the immune response. Now, the question, though, is that particularly for the adolescents and the adults, is this reemergence of pertussis just because the immune response seems to lessen over time, or is it that, in fact, the overall response that the vaccine induces just is not as effective, or is it, in fact, that we have an emergence of different strains of or changes in the genotype or the genes of the pertussis bacterium? Because even in outbreaks of pertussis, if you try and go through and actually do genetic typing of the various people who are infected, what you find is there's not one single genetic type that's occurring in the outbreak. It seems to actually be a multitude of types. So if you want to be completely confused and befuddled until you finally just say, okay, I know I can go through this and think about it. This is your immunization chart for children who are 7 to 18 years of age. It looks rather overwhelming, but it's really not when you start to break it down from the CDC, and it tells you which vaccines they need, for example, between the ages of 7 to 8, between the ages of 9 and 10, between the ages of 11 and 12, okay? Either those that are recommended unless your child can't safely receive the vaccine, or that are truly recommended if you, in fact, have a child with certain health conditions, if they're catching up on their vaccines, what to give them. And then this is for children who aren't necessarily at increased risk, but who really want to get the vaccine after they've talked to their provider. So if you take a minute and just not get too overwhelmed by all the variety of colors and columns, what you find is that it's actually fairly intuitive here. Anyone who shows up in your office before the age of 18 that hasn't completed their series of their Tdap needs to get their shots. If they show up and they've had their series and they're between the ages of 11 and 12, they need to get the booster shot, okay? Now, this is actually the slide for adult patients. And basically, if you are older than 19 and you have not gotten your Tdap booster, you need to get your Tdap booster. The question, of course, and one of the areas of research I'll touch on slightly later is, well, we're doing this almost as a one-time booster for adults, but maybe we actually need to be doing this on a more frequent basis in the adult population as a whole every so many years, just like we have to get a tetanus update every so many years. And in fact, there's recommendations from the CDC that women not only get their Tdap during their first pregnancy, but they also get it with every pregnancy. And we'll talk more about that in a little bit. So we have our adults and our adolescent vaccinations between 13 and 17. Most of the adolescents and what I call the young adults, or still teens, are in fact getting immunized, which is great. The problem, of course, is that once a child turns 17 or 18, they either go off to college and parents are not really or their guardians are not completely on top, being able to be on top of things and making them go to the doctor and dragging them to the doctor and browbeating them into getting their shots. And so we know the vaccination rate seems to wane after that. The next strategy, sorry about that. This is a slide looking at the various disease outbreaks and the exemptions in the state of Texas, because I think the critical slide that Essi showed earlier were the non-vaccination rates among the various ethnic groups. It's quite arguable from a public health perspective that Hispanics have a lower vaccination rate because, or the highest the highest rate of not getting vaccinated due to access to care problems. However, the next highest groups that don't get vaccinated are the Caucasian or the white groups, and that is in fact because of the hopefully diminishing but still ever present anti-vaccination trend and movement across the United States. So when you look at where there are exemptions in 2013 from getting vaccinations for any reason the patient decides, either religious or just I seem to think this is a bad idea and I don't want to get my child vaccinated, there's absolutely no health reason why they can't be vaccinated. And then you look at where these outbreaks actually occurred, it's not a surprise that there's overlay in at least 2 of the non-medical exemption areas here. That is quite honestly epidemiologically common sense when you actually look at it. The challenges that we currently face, as I mentioned, is that the childhood vaccination, the booster dose, may actually need to occur a little earlier than 11 to 12. It might need to occur between the ages of 7 to 10, but we need to get the data on that epidemiologically, and trials would need to be done. Most adults don't know that they need to get a Tdap or a Pertussis booster, and in fact, very few people are fully protected within 4 years, 5 years or later after getting the Tdap, and they will need a booster exam. Now, I mean a booster vaccination. The current strategies also included at one point the concept of cocooning, which made a lot of sense. The idea was that if you have an infant at home and the infant can't get vaccinated because they're too young to receive the vaccine series, then maybe if we vaccinate those who are around them, who are spending a lot of time with the baby, and make sure that they are in fact vaccinated, that we could help limit the opportunities of exposure for the infants. So if you look at the pertussis vaccination rates with the cocooning over the ages of 19, which sort of leaves a wide spectrum, because we know that increasingly older women are having children. So when you're thinking about what's the age range here for who could possibly be exposing a young child, at least maternally, it goes from 19 all the way up to 49 or 50, quite frankly. And this also takes into account the fact that you have the multi-generational effect living within the same household. So in the last 8 years, what we have found is that in certain groups, we have seen an increase in the uptake of the vaccine, but clearly it's not nearly as robust as what it actually needs to be in order for us to have a bigger impact. The other issue with cocooning is that it's extremely logistically hard to do for a number of reasons, either insurance or access. And we thought that perhaps, we'll immunize mom before she goes home from the hospital, and we'll tell her that dad needs to be immunized, or the other care providers need to be immunized. But honestly, it's not always as simple as it sounds to be able to find a provider that actually carries the vaccine in their office. They're not sure where to go. They might have issues with not being able to access due to insurance reasons, the other providers. And as a result of that, it wasn't really widely used. And there is some evidence that, as appealing as the concept is, it may not be effective. It is not effective completely by itself. Does that mean it's not worth trying to do? Absolutely not. I think it's worth trying to do because in the end, what are we really doing? We're vaccinating as many people as possible. And that at the end of the day, even if it's not a lifelong immunity that we're imparting to them, we are in fact bolstering their immune response and providing them, at least for the first 1 to 3 years, with a robust response that would give them some immunity to the disease. One of the biggest changes that has come about is the understanding that we really need
I'm sorry, everybody. It appears that we've lost Dr. Curtis. Dr. Curtis, is it possible that you've accidentally muted your phone? All right. Well, Dr. Curtis, if you wouldn't mind hanging up and then calling back in, and hopefully we can fix that audio glitch. And I can talk a little bit while we're waiting for Dr. Curtis to get back on and talk a little bit about maternal vaccination, which is what Dr. Curtis was getting to. And so this is a relatively recent recommendation. Yes, great. Excellent.
Great. Okay. I just switched over to the microphone instead. At what point did you lose me?
We left you just as you were introducing maternal vaccination.
Okay, great. So the maternal vaccination originally had started, the push to try and do it occurred first in vaccinating women right before they went home from the hospital with the newborn, thinking that that was, we might be able to catch more women that way, and then possibly even advance the concept of the cocooning, of trying to place people around the baby who in fact are immunized effectively and seem to have the most robust response to the vaccine because they recently achieved it. What we found, of course, is that, as you know, is that maternal vaccination can occur long before the baby's actually delivered, and it will give time for the maternal antibody systems to kick in. So it is recommended that women over 20 weeks of gestation do receive a Tdap vaccine. And part of what I do is work at a variety of large and very busy clinics around the city of Houston, and I'm pleased to say that most of them, including the private offices where I've also had an opportunity to work, have a standard policy. Somewhere between 25 weeks, women are recommended to have the Tdap or the Pertussis vaccine, and we tell them why. Now, how it is that the antenatal vaccine completely, or at least provides such robust protection to the newborn, is a little bit unclear. It's not entirely sure if the fetus is actually receiving the antibodies from the mom via the cord blood, and possibly even in the breast milk in the form of IgA antibodies, or whether or not it's that mother is in fact robustly protected and she is acting as a shield to try and help protect transmission to the fetus itself. But there are some concerns. The question, as with everything in pregnancy, research in pregnant women is rather limited. So there's a plethora of scientific questions about, does the maternal vaccination have any effect on the antibody or the immune response in infants when they receive their own shots later on, and we don't know that. So there's a lot of questions that we don't have, and a lot of opportunities for research in that area. Currently, the idea, however, is that knowing that the acellular vaccine leads to a decrease in immunity over time, that women who are pregnant should get a Tdap vaccine with every pregnancy. There's no evidence of any adverse effect for either the mother and or the infants. And of course, the option of potentially considering getting an adult booster every 5 to 10 years has been raised as well. So with pregnancy, I can tell you the 2 shots every pregnant woman should be offered between 27 and 36 weeks. Although, again, you can give it as early as 21 weeks, is a flu shot and a Tdap. Just to diverge slightly, the flu in pregnant women is a much more virulent disease for the maternal health than the flu in a non-pregnant woman. And we know that the flu shot provides protection. Now, when you see a patient in the office or in the clinic, or if you're advising someone in terms of what to expect, we all know that it's not just what you say, it's also how you say it. So rather than asking, would you like the Tdap vaccine today, which assumes that the patient or the client understands and knows the risks, the benefits, the science that this recommendation is made on, and has researched it and understands it, if we express from a healthcare standpoint, I would like to give you the Tdap vaccine today because that will protect your baby from pertussis. Do you have any questions? That presumptive type of approach clearly allows for an open dialogue to occur, but it also makes it very clear that this is a recommendation. This is not just a matter of would you like it or would you not like it. And I think that's important because as much as patients are their own final decision makers for their health care, they do rely very heavily on the healthcare providers and the expertise of the healthcare system. Offering the vaccine, would you like it, is not the same thing as recommending it. So the recommendation would be that I as your provider want you and your baby to be protected, and I think it's important that you get the vaccine today. Clearly this can be expanded upon to try and give some knowledge about the disease. What is it? How is it spread? Why is it such a big concern nowadays? What's the problem? Instead of saying simply, well, if you'd like, we can vaccinate you. But not too many people would say, oh yes, I really enjoy getting a needle jabbed into me and I'd love to have a vaccine today. So if we're actually going to say this is our recommendation, then the way that we say it, how we say it, has to make it clear that this is a recommendation on our part. It is not just simply an inquiry as to whether someone likes the concept or not. And that strong provider recommendation is critical to vaccine uptake. The fact is that particularly pregnant women and mothers of children are very interested in trying to protect their health, and they do want to know, what does the science say? What are the current recommendations based on the evidence that we have? Now, some patients are going to respond and simply say, yes, that sounds great, I'm happy to get that. Other patients may say, and they may step back. At which point, the most important thing is to ask someone, what are your concerns? Don't assume that you know what they are. Don't start listing the commonly listed concerns you happen to hear every day. Ask them what they're worried about, because sometimes what you find is what their concern is nothing you've heard before, or it's not related to what you thought it might be. And by allowing them to express their concern, then that helps you address that concern specifically to that patient in the context of that patient's life. And you can also then pull out of your brain what you know that the science says with regards to that concern, and you can then give your advice based on that science. So I think that sometimes in our haste to try and educate people and to try and make recommendations, it's just as important, if not more so, to step back and listen and ask the patient, what's going on? What do you think? What are your concerns? The problem with the current strategy of maternal vaccination is that not all prenatal care providers stock vaccines at their sites. You have issues around storage, around tracking the stock, keeping track of the expiration dates, and of course issues associated with reimbursement, the ever-present nemesis of the current healthcare system. We know what works, we know what's great. It doesn't necessarily mean that that's where the system has decided to put its funding money to make sure that that's what happens. So what do we need to do? Well, first of all, we need to increase both the education and the outreach and the dialogue among key populations. We need to find out what some of the concerns are, and also make sure people are aware. What is pertussis? There are patients who, when I say pertussis, get a blank look, but they may be a bit uncomfortable trying to tell me, well, you're saying it like I should know, so if I say I don't know, I'll look stupid. So you have to gauge, what's the response I'm getting, and then if you get that blank look, then you say whooping cough. And at that point, most people will say, oh yeah, I've either heard about that, or yes, I know what that is. We also need to increase our collaborations with pharmacists, because increasingly the pharmacy is where people get their vaccinations. They don't necessarily go to the doctor's office or to a clinic or even a city health department for it. And I think this is great that we have another cadre of healthcare professionals who are knowledgeable about the vaccines and can give them. But we also need to focus on what are our current policies that encourage uptake and increase access. And I personally believe that if there's not a medical contraindication to getting the vaccine, a health reason that you can't, then in fact you should get the vaccine. And we're seeing that increasingly there are policies even within the healthcare settings, for example, hospitals, that basically make it clear that without a medical documented reason that you can't receive the flu vaccine, you will either accept it or you will no longer work here. And of course, as I'll talk a little bit earlier, we need to improve the vaccine effectiveness. So if we're talking about increasing education and outreach, who are we going to talk to? Well, providers are one, because if you don't think of the diagnosis, you will never make the diagnosis. So when patients show up with a recurrent cough, even if they're 2 weeks out, it doesn't mean you don't do the testing. It just means that based on their clinical symptomatology, even if the diagnostic testing is negative, you should still suspect pertussis, and you should be asking them, who are you around? Are you around any newborns? When was your last pertussis vaccine? So with providers, it's not just a matter of having them provide more vaccinations, it's also raising the suspicion level for the disease and screening earlier. If someone comes in with the cold and this cough, doesn't seem like a regular cold, and you know that you're in the midst of a recent epidemic and they're in the right age group, then go ahead and do the diagnostic testing. You want to do a high nasopharyngeal swab, though. It's not just putting the Q-tip just at the very bottom of the nose. We want to outreach more to pregnant women to make them aware that they can provide the line of first defense for those newborn infants that they're taking home, and that in fact they are the ones who can tell their family members, I do not care how difficult this is going to be for you to get your Tdap vaccine, but I got mine in this pregnancy and you are going to get yours in this pregnancy. Adults with infants under 1 year, obviously, if they've not been told, they need to be told. So don't assume that because a mother walks in with a baby that's 2 months old or is a month old that she got the Tdap vaccine. Don't assume that she knows she should have. You need to ask, and we need to vaccinate them. Child care workers need to be vaccinated, as well as the pharmacists. And we also need to make sure that the health care providers, the nurse practitioners, the physicians are all also up to date on their immunizations. And if it turns out that in the long run we should all be receiving boosters more frequently than just once in a lifetime as an adult who isn't pregnant, then we need to also work on that. For the collaboration with the pharmacist, they can provide additional immunizations. And I think communicating with the pharmacist is really critical, because healthcare is a multi-level endeavor. It is not a single point of contact. There are a number of people on the team as we all try to work to take care of the patients that we see. And pharmacists are vital members of that team, and we need to make sure that they're included when we're crafting policy as well as educational outreach endeavors. We also need to enact policies that encourage uptake and increase access. The immunization registry should be an opt-out. You should have to say, I don't want to be in that registry, not I want to be in that registry. One of the criticisms for the vaccine schedule is that there seems to be a lot of vaccines over time. It's hard to keep track of, and let's face it, most people's insurance changes, if not every year, then every few years. And it's not as if we all remember to necessarily go get a copy of the records from the prior physicians' offices that contain all the information of what was done to us. And we may not remember, particularly as we get older, whether or not or how long ago our last shot was. If we have an immunization registry where people are automatically entered every time they get a vaccine, then that is tracked, and it's easier to access and to keep track of. We need to tighten the exemptions around school vaccine requirements, because the fact of the matter is I shouldn't have to send my children to school and have them around a herd of other children who are not immune to a disease, and my child has an immune problem or is undergoing chemotherapy or has some health condition that precludes them from getting a vaccine, and yet they're now at increased risk because they can no longer rely on that herd immunity. And we should also consider modifying the schedule. Maybe we should give the booster doses earlier as well as give them earlier. There should be an adult safety net program as well, so that commercial pharmacies and other places can actually participate in giving vaccines, and we should broaden the criteria of who can have access to adult safety net programs so that more low-income people can get it. We need, in short, to do two things. We need to develop a vaccine with good safety, long-lasting immunity, a decrease in the infection burden in society, as well as a vaccine that prevents transmission, not just one that decreases the severity. We also need to develop therapeutic agents and treatment strategies to decrease the mortality and the morbidity in the vulnerable populations. In the early course of pertussis, I can give someone an erythromycin-based antibiotic regimen, and that may help lessen the severity of the disease, but it will not cure the disease. They will still have the disease. They will still be, it may lessen the transmission rate of the disease. But I have to catch that in a very, very early window within the onset of the clinical disease, and most of the time that is missed. So not only is it vaccines we need to look for, but we also need to look for better ways to treat people when they come down with pertussis. So there have been suggestions, as I said, to go back to the former vaccine, the whole cell vaccine. But the trade-off there is, are we willing to accept the fact that it seems to have a safety profile that is not as good as the acellular vaccine? And if we do, does that mean the public is willing to accept that? Or is it going to undermine their confidence in the vaccines when they see more reactions? And again, we'll see a retreat from vaccinations. We may also consider a mixed approach. There's some evidence that the timing of the vaccine as well as the type of vaccine that's used may play a role in establishing longer-term immunity. So there's been a suggestion that maybe we should start off with the whole cell vaccine and then go to the acellular vaccine later on. There's also been discussion about using a vaccine that actually contains a live but very weakened form of the bacterium. There are suggestions that maybe if we change the chemical composition of the vaccine, not just the things it's attacking or protecting against, but actually the chemicals the vaccine and its components sit in, the adjuvants, that may change the immune response and boost it as well. Maybe we just simply need to come up with an entirely new vaccine. So while there are problems, and I think I've covered them pretty well with the current vaccine that's in use, the fact of the matter is it's the best tool that we have. And I don't understand why you would want to hit a nail with your fist when you have a hammer sitting next to you. It may not be the best hammer in the world, but it's a hammer. So we need to increase the vaccination across the populations and recognize that pertussis, while its most profound and lethal impact is on the young child, particularly in the first few weeks or months of life. The fact of the matter is the whooping cough is not just a disease of childhood. It also impacts young adults, it impacts adults, and it impacts older adults. And therefore, from a public health perspective, it's not a disease that belongs solely to the pediatricians. So I'll conclude at this point in time and take any questions anyone may have.
Thank you so much, Dr. Curtis. Really appreciate all that very, very interesting information. So, you know, I think that I really appreciated what you said about it being a really complicated, complex disease to address because of all the different factors. And of course, we heard a very long list of different kinds of policy changes that might affect it. I'm just wondering, Dr. Curtis, if you could change one thing, if you had your magic wand and you could change one thing about the way we address pertussis, what would that be?
I think that I would change it by basically saying you no longer get to opt out of a vaccine unless your physician or your healthcare provider can provide medical documentation as to why that's necessary. In other words, universal vaccination. It's not 100%, but it is the best that we have, and I don't want to use a suboptimal tool. I want to use an optimal tool, and that's what we've got right now.
Okay, great. Thank you so much for that. Okay, we have another question. This is for Dr. Curtis. So if you have a question for one of our panelists, please type it in the screen on the right-hand side, and then we will be able to look at those questions and read them out. So now's the time for all questions that you have. Okay, so Dr. Curtis, we do have a question. How familiar are OB-GYNs with the maternal vaccination recommendations? How can we better engage that group of providers to boost maternal vaccination?
Well, I think to be honest with you, the American College of OB/GYN has been very emphatic over the last several years. In fact, going on over 5 years now, about closer to 10, about the need to vaccinate women in pregnancy against flu and against pertussis. They send out toolkits. They make it very clear in their guidelines for perinatal care as well as in their women's health care guidelines. I think the real struggle, particularly in the beginning, was that OB/GYNs, like most other non-pediatricians, were not known as being vaccinators. And it's been a slow uptick in pickup in terms of, well, where do I get the vaccine and how do I buy it and does insurance cover it and how do I code for it and how do I get reimbursed? And this was stymied in part by the fact that in some instances, the reimbursement rate for, basically by the time you were done, you either lost money on providing the exam out of your office budget, or you broke even and yet you were diverting attention and resources to an endeavor that has great public health benefit, but at the end of the day, you still need to pay your bills. And so if you are spending resources and time on something, you'd like to see, if nothing else, a monetary return on some of that investment, and they weren't. I think slowly that's getting better. I don't think there's any hesitancy among the OBGYN community in their recognition that, yes, we need to provide these vaccinations, and yes, they are important. But there is going to be that learning curve of how do I set my office up to be able to do these vaccines. For some of the larger healthcare systems, it wasn't that difficult. So, for example, for some of the larger clinics here in town that see a very high number of Medicaid patients for their prenatal care, it's just automatic. It comes up as a reminder. The patient is now 26 weeks. Between 26 and 30 weeks, she needs her Tdap vaccine. You can't avoid being reminded, and it's done. So the smaller offices, I think, have a slightly harder time, and it's more in terms of logistical issues. There's no recalcitrance on their part or hesitation that it's not the right thing to do. They do know it's the right thing to do.
Okay, great. Thank you for that. We have another question, and this is either for Essi or for Dr. Curtis. Do you recommend adults receive titers to see if they were still protected?
Essi, do you want to take that, or would you like me to answer it?
Go ahead, Dr. Curtis.
Well, the titers, the interesting thing about the titers is that the immune response to the acellular vaccine, to measure different immune levels or different immune factors and how they react to the vaccine, shows that you get a very robust response. The problem is there's not a single blood test I can do to measure a single chemical that would be represented in a titer. Okay, because the immune response, even to natural pertussis as well as the vaccine, is comprised of a lot of different immune factors. We don't have a good correlate of, okay, this is the factor we can measure that will really tell us not only if it really responded, but if it's also really effective. So, for example, among those factors with your whole cell vaccine, your THP2 and 3, which are specific immune factors, those actually seem to be more stimulated, much more so than what we see in the acellular vaccine, which seems to cause a rise in a THP1 factor. Now, if we know this, then why don't we measure those? Well, because those are normally labs that are done in research labs. They're not readily available tests. So we not only need good molecular correlates or factors we can say, yes, this is what we can measure to see how good is the immune response going to be, not just how well did it take to the stimulation of the shot, but how good is it going to be at fighting the disease. For a long time, we also really lacked any sort of good animal model. Although recently, there's some excitement in the literature because it appears as though we may have finally landed on an animal model in baboons that more closely mimics the human immune response than what we had, for example, in the mouse or in the pig model. And that will hopefully make it easier for us to answer some of these questions.
Okay, great. Thank you so much for that response. Okay, we have another question about the immunization registry, what it is and what opt-out would mean. So let me just explain that a little bit more in detail to the participants. So Texas has an immunization registry that's called IMTRAC. In this immunization registry can have information about children or adults, so it's a lifespan registry. Unfortunately, adults are not required to have their information in the registry, but children are required to have their information in the registry. However, children are required, but there's no enforcement mechanism to make sure that they have their information in the registry. And Texas is one of just a handful of states that requires consent to be in the immunization registry. So this is a real problem because, I mean, the basic function of a registry is that you can get a shot from any doctor, and it's all fed in, all of the information from all these providers is dumped into one central repository where they can pull up your information at any point of service and see which vaccines you've gotten. So it can be a very efficient, very helpful resource in a community. Unfortunately, Texas has a very, very weak immunization registry because of our laws and because of the fact that adult immunizations don't make it in there. And if we're being real, childhood immunizations often don't make it in there because of the rules around consent. Most states, you treat a patient at your clinic, that information goes directly to the state and it's put right into the registry. So that if that child shows up at another provider's office in a month or two, the other provider can pull up, can look at the records, can see what you did. And it saves a lot of vaccine because you're not doing duplicate vaccines, but it also helps you identify gaps. And when you have a law that requires consent to be obtained, that becomes very burdensome for the provider and for the family, and it becomes an administratively burdensome process for the state to manage. And as I said, in Texas, we do have this law requiring consent. And so the data in the registry is very incomplete, and it's not considered a very reliable source to go to if you're trying to figure out what immunizations a child or an adult has had. So there has been a movement for the past 10 years to switch the registry from an opt-out registry to an from an opt-in registry to an opt-out registry, meaning basically that you don't have the option whether or not you want to be in there. You just have the option to ask for your information to be removed. So it's more like a default where all of the information goes in except for the people who have stated that they don't want to be in there. So in Texas, we also know that 95% of people, when approached, want to have their information stored safely in the registry, and only about 5% want to not be in the registry. Right now, we're collecting consent on 95% of the population in order to exclude 5% of the population. So what we've been trying to do with the legislature is flip that and not worry about collecting consent on 95% of the population, only worry about collecting the written notification from patients who choose not to be a part of the registry. It's a fairly complex topic. We invite you to learn more about it and learn more about our advocacy efforts around it, either by getting in touch with us or by going to our website at immunizeusa.org. You can also sign up to get action alerts. The next legislative session will be starting in January, and you can sign up to get action alerts and keep up to date on what's happening with the registry. So I'm going to leave it at that. If anybody has more questions, please type them in the box on the bottom right-hand part of your screen.
Anna.
Yes.
This is Essi. Can I add something to the MTRAC?
Yes, ma'am.
Okay. So I just want to share with the participant that it's really amazing. I know I moved from Nebraska, Omaha, Nebraska, and we don't have that issue, the issue there. But we did a big audit in delivery hospital this year, and it's amazing that 97% of infants born in Texas for the last 2-3 years, they have been consented to be in MTRAC. So the job right now is to motivate our providers, the pediatricians who are seeing these kids, to look into MTRAC, to search the record to find out if they are in MTRAC first, and also continue to enter the data into MTRAC because they consented already to be in MTRAC at birth. That's one thing that I found this year when we did the audit in 24 delivery hospital in Harris County.
Yeah, and actually that's a good point, Essi. The birthing hospitals are doing a great job of getting kids in. The problem comes when, so the vast majority of people want to be in the registry. That's the other thing that your comments demonstrate. The problem is when we have kids coming in from other states that need to be consented at a doctor's office, or for children who have home births that are not going through a birthing facility. So we are making progress definitely in the birthing hospitals. So kudos to all of you in the birthing hospitals that are doing a great job of collecting that consent. Unfortunately, it's not as robust as it could be if we didn't have that problem with consent. But yeah, thank you for highlighting one of the bright spots, Essi. I appreciate it. Are there any other questions out there? If there are, please type them in the box. And while we're doing that, I'll just ask our panelists, Essi and Dr. Curtis, if you have any closing thoughts. Essi, we can hear from you first.
Oh, well, I will recommend that some of our providers, I know Dr. Curtis kind of touched on some of the issues why, the pregnant women are not getting the vaccine related to the storage, the technical issues. And I know we have some resources, some great resources in Texas, as she mentioned, Adult Safety Net. So I really want to encourage the providers to reach out and find out about the resources, or if we have any participant on the webinar who is interested in working with us, we would love to share the resources with them where they can refer the patient who are uninsured for Tdap. So that's one thing that I want to share with the participants.
Great, thank you, Essi. And Dr. Curtis, do you have any closing thoughts? Maybe one thing that people can do as a next step to address this issue?
Well, I think the thing that has always stuck in my head was, close to 2 decades ago when I started to get a better understanding of the fact that pediatricians aren't the only people that need to be giving shots and kids aren't the only ones who get them. I remember my instant response is, well, yeah, but tricks are for kids because that's the serial motto, and people seem to have extended that to immunizations are for kids. And the fact is, tricks are for kids, immunizations are for everyone. Go get yours.
Great. So, Dr. Curtis, thank you for reminding us that we need to practice what we preach. Those of you who are on the line, if you don't know whether or not you're up to date with your Tdap or with your Pertussis shots, most likely in the form of a Tdap, please find out and get up to date if you are not. With that, I think we are done for this evening. I would like to thank our panelists once again, Dr. Curtis and Essi. We appreciate your time and your effort and your wonderful advice. And if you are getting continuing education credits for this, please go to immunizeusa.org/education/pertussisCEU. You can find all the information that you need there. We appreciate everything that everyone has done to make this possible tonight, and we welcome your feedback. With that, the slides from today's presentation will be uploaded onto our website, immunizeusa.org. Please take a moment to fill out the post-test and evaluation. We appreciate your feedback, and with that, we are adjourned. Thank you, everyone.
Thank you.
Thank you.